Hello, my name is Chelsea Chibuzor, and this video project will be about me talking about anorexia nervosa and its neuromechanisms. Anorexia nervosa is a type of eating disorder. Eating disorders are mental health problems that cause extreme and dangerous eating behaviors. These extreme eating behaviors cause other serious health problems and can even cause death. People with anorexia nervosa eat so little that they have unhealthy weight loss and become dangerously thin. Anorexia can affect people of all ages, genders, sexual orientations, races, and ethnicities. Although the disorder most frequently begins during adolescence, an increasing number of children and other adults are also being diagnosed with anorexia. It is more common among girls and women than boys and men. There are several symptoms for this eating disorder. It can cause physical and psychological changes. Some symptoms can include sadness, thin, brittle hair and nails, feeling faint, dizziness or weak, irregular periods or never getting a period for girls, dry, blotchy, or yellow skin. Some behavioral changes can include eating very little, refusing to eat in front of others, making yourself throw up, taking laxatives or diet pills, exercising a lot, and many more. Causes of anorexia. The exact cause is unknown, but there are other known factors. Genes, hormones, having anxiety disorder as a child, having a negative self-image for yourself, having eating problems during infancy or early childhood, trying to be perfect or overly focused on rules. Researchers are also studying unusual activities in the brain, such as changing levels of serotonin or other chemicals, to see how it may affect eating. I'll be talking about the role of the serotonin neural function in anorexia nervosa later on. Treatment plans can include nutrition therapy, where doctors, nurses, and counselors will help you eat healthy to reach and maintain a program to make sure they eat enough to recover. Psychotherapy also helps you. This is where you're counseled to help you change any harmful thoughts or behaviors you have about yourself. Support groups also can be helpful for people. Meeting with family members and sharing your story is also helpful as well. Medicines like antidepressants can help some girls and women with anorexia by improving depression and anxiety symptoms that often go along with anorexia. I'll now be focusing on the neuromechanisms of anorexia nervosa. This figure here shows the cycle of self-starvation and anorexia nervosa, a representation of the development of compulsive weight loss habits in anorexia. As you can see, goal-directed weight loss behaviors such as food restriction and exercise can lead to weight loss. Weight loss is experienced as rewarding, which may be positively reinforced by an increase of dopamine in the ventral striatum. The pursuit of the rewarding aspects of weight loss leads to repetition of weight loss behaviors. Disorder-related cues may gain insensitive salience through condition reinforcement and may themselves trigger weight loss behavior. Repetition of rewarding weight loss behavior may result in synaptic changes in the dopamine pathways and result in dopamine hypofunctioning in a similar way to substance dependence. The avoidance of negative states and the anxiety associated with food may become more important in reinforcing weight loss behaviors in the later stages of anorexia. Starvation and malnourishment further promotes weight loss behavior in the following ways. The upregulation of reward associated with starvation may lead to disorder-related cues gaining insensitive salience through a molecular cascade in which starvation-induced reduction in glucose and insulin lead to an increase in phasic dopamine transmission in the ventral striatum. Furthermore, anorexia is associated with increased sensitivity to both reward and punishment, which may enhance both positive and negative reinforcement of weight loss. Stress is associated with a reliance on habits and learning, and the stress associated with starvation may promote the compulsive weight loss behavior seen in anorexia. Once weight loss behavior is repeated enough, a rewarding outcome may no longer be needed for behavior to continue, and weight loss behaviors may become compulsive and habitual. This figure shows the time course and phenomenology of anorexia. Childhood personality and temperament traits, which contribute to a vulnerability for developing anorexia, become intensified during adolescence as a consequence of the effects of multiple factors, such as puberty, and gonadosteroids, development, stress, and culture. Individuals with anorexia find that dieting reduces and eating enhances dysphoric mood. But with chronic dieting and weight loss, there are neurobiological changes which increase denial, rigidity, and obsessions, as well as depression and anxiety, so that individuals often enter a downward spiral. Although 50% or more of individuals with anorexia recover by their early to mid-20s, a significant proportion of subjects develop a chronic illness or even die. This figure shows the role of serotonin neural functions in anorexia. It is well known that people with anorexia enter a vicious cycle whereby malnutrition and weight loss drives the desire for further restricted eating and emaciation. Evidence suggests that compared with healthy individuals, individuals who are vulnerable to develop an eating disorder might have a trait for increased extracellular serotonin 5-HT concentrations, which together might contribute to increased satiety and an anxious, harm-avoiding temperament. Gonadosteroid changes during menarche or stress related to adolescent individuation issues might further alter activity of the 5-HT system and so exacerbate the temperament, resulting in a chronic dysphoric state. It is important to note that food-mood relationships in anorexia are very different from those in healthy controls. That is, palatable foods in healthy subjects are associated with pleasure and starvation is aversive. By contrast, palatable foods seem to be exogenic in anorexia, and starvation reduces dysphoric mood. In subjects with anorexia, starvation and weight loss result in reduced levels of 5-HIAA in the cerebrospinal fluid, but exaggerated 5-HTIA receptor binding in limbic and cognitive cortical regions. Starving-induced reductions of extracellular 5-HT levels might result in reduced stimulation of postsynaptic 5-HT1A and 5-HT2A receptors, and thus decreased dysphoric symptoms. However, when individuals with anorexia are forced to eat, the resulting increase in extracellular 5-HT levels and thus stimulation of postsynaptic 5-HT1A and 5-HT2A receptors increases dysphoric mood, which makes eating and weight gain aversive. Alternatively, if subjects with anorexia continue to starve, anorexigenic signals related to neuropeptide disturbances might drive further food restriction and changes in behavior and cognition, which thus promotes anorexia symptoms. Anorexia has the highest mortality rate of any psychiatric disorder. It is expensive to treat, and we have inadequate therapies. It is crucial to understand the neurobiologic contributions and their interactions with the environment in order to develop more effective therapies. Therefore, future imaging studies should focus on characterizing neural circuits, their functions, and their relationship to behavior in individuals with anorexia. Genetic studies might shed light on the complex interactions of molecules within these neural circuits. Finally, prospective and longitudinal studies should focus on identifying the neurobiologic traits and external factors that create a susceptibility for developing anorexia. Thank you.